Hello friends, my name is Swarnim Adhikari and I am 4th year medical student from Institute of Medicine. So in this video on series of gynecology lecture, I am discussing on the topic of endometriosis. So this is one of the very important topic of gynecology and we will discuss about this topic in this video. So what is endometriosis? It is the presence of functioning endometrium, that is both gland and stroma, in sites other than uterine mucosa. So there is presence of ectopic endometrial tissue in the other side than the uterine mucosa. So these ectopic endometrial tissue may be found in any site other than uterus. So there is two terminology known as, one is endometriosis interna versus endometriosis externa. So what is endometriosis interna? It is another name for adenomyosis, in which there is the ectopic endometrial tissue is found in the myometrium, whereas in endometriosis externa these tissue are found at other site than uterus, and this is commonly what we call endometriosis. Endometriosis externa is endometriosis, and we are mainly discussing about this in this video. So it is the endometriosis is very defined as disease of contrast. So why this is known as disease of contrast? Because we have just three reasons why it is due to its contrasting feature. So firstly, endometriosis is one of the, it is benign condition, but it is locally invasive and disseminate widely. It is benign, but it is locally invasive and disseminate widely. So it is very contrasting feature. It has very contrasting feature. So this is good. That's why it is called disease of contrast. And second reason is that the cyclic hormone stimulate growth, but continuous hormone suppress it. So cyclic hormone stimulate growth, but continuous hormone suppress it. That is another contrasting feature. And thirdly, with women with extensive disease may remain asymptomatic, whereas a patient with minimal disease may have incapacitating chronic pelvic pain. So the symptom may be less, they may be asymptomatic in more extensive disease, and the symptom may be severe in the very minimal disease. So that's why it has very contrasting feature. So that's why it is called disease of contrast. And endometriosis is a aggressive, progressive and invasive disease. So during last couple of decades, the prevalence of endometriosis has been increasing rapidly. It might be due to delayed marriage. Nowadays people are becoming modern and they are delaying their marriages. They are postponing their first conception, and they are adopting very small family norm, due to which they are following they are very less parity. So, and also there might, and other reason might be there because of nowadays more facilities are there, the increased use of diagnostic laparoscopy, as well as there is heightened awareness of disease among the gynecologists. So these endometriosis is being diagnosed rapidly. So this might be reason why there has been the endometriosis may be more prevalent nowadays. And not talking about the sites where this endometriosis can be there, the endometriosis can occur at any site of the bodies. It can even occur at nose and CNS. So, but what are the most common site? The most common site is, first of all, ovary. Ovary is the most common site of where the endometriosis is found. Second is pouch of Douglas, pelvic peritoneum, uterosacral ligament, rectovaginal septum, sigmoid colon, appendix, fallopian tube, and pelvic lymph node. These are the common site where the endometriosis lies. So let's revise it again. This is very important. Ovaries, pouch of Douglas, pelvic peritoneum, uterosacral ligament, rectovaginal septum, sigmoid colon, appendix, fallopian tube, and pelvic lymph node. And some other rare sites are umbilicus and scar tissue like abdominal scar, episiotomy scar. It may be in the lungs and pleura, ureter and kidney, arms and leg, nasal mucosa. So these are some rare and very remote site of endometriosis. So we are now talking about the risk factor of endometriosis. The endometriosis has the risk factor like low parity, early menarche, late menopause. In this condition, there is very high estrogen level. This is hyperestrogenic condition, and in this condition of low parity, early menarche, late menopause, there is high chance of endometriosis. And there secondly, the delayed childbearing, as you already said, if there is a family history of endometriosis, if there is genital outflow tract obstruction, there will be retrograde flow, and that will cause endometriosis. We will discuss about this theory, about Samson's theory. And another is environmental toxins can predispose to endometriosis. Another is peritoneal fluid abnormalities, and even white and Asian female are more risky for endometriosis, and women with low BMI are more prone to endometriosis, low BMI. So what are if these are risk factors, then what are the protective factors for endometriosis? So it is almost exact opposite of these risk factors. So here you can see here the protective factors are multiparity. Low parity was the risk factor and multiparity is the protective factor. Late menarche is the protective factor, but early menarche is risk factor. Oral combined fluid is protective for endometriosis. Why? Because OCPs cause anovulation and there is decreased blood flow in the endometrium. And also the consumption of omega-3 fatty acid is protective, and surprisingly smoking is protective for endometriosis. Smoking inhibit aromatase and prevent conversion of androgen to estrogen, and there will be less estrogen, and that will prevent from endometriosis. So that was about the risk factor about the endometriosis and protective factor. Now we will talk about pathogenesis of endometriosis. The pathogenesis of endometriosis, it is very still unclear how this endometriosis occurs, and it is full of theories. There are different theories, and the principal theories we are going to discuss is first one is retrograde menstruation or Samson's theory. So what happens is that normally in females menstruation occurs only in forward direction, whereas in female with endometriosis both forward and retrograde menstruation occurs, and due to that the superficial endometrium that are to be shed comes to the fallopian tube, and they even go to the ovaries and pouch of Douglas, and where they implant and these there is occurrence of endometriosis in this site. So this explains how does the endometriosis occur in fallopian tube, ovary and pouch of Douglas. The retrograde menstruation is mostly occur in the female. We have the condition like imperforate hymen, where there is blockage of the outflow tract, and that risk increases the chance of endometriosis. So this theory explains the explanation. This provides the explanation for pelvic endometriosis, and so this theory doesn't explain how there is occurrence of endometriosis in remote site like pleura, lungs, diaphragm, umbilicus, and so that was about retrograde flow or Samson's theory. So now talking about lymphatic and vascular theory, this is given by Holban. It may be possible for normal endometrium to metastasize like cancer. Endometrium also metastasize, and they reach to the pelvic lymph node through the draining lymph channel from the uterus. So this theory explains the occurrence of endometriosis in lymphatic theory. Next, third theory is the coelomic metaplasia theory by Mayer and Ivanov. According to this theory, the chronic irritation of pelvic peritoneum by menstrual blood may cause coelomic metaplasia, which results in endometriosis. It may be explained by the fact that the adult stem cell and mesenchymal cell has the potential to have multipotent development. The coelomic epithelium can grow into any tissue as they are multipotent. So that the coelomic epithelium can undergo metaplasia, and they may change into endometrial tissue. So this theory explains the endometriosis of abdominal viscera, recto-vaginal septum, and umbilicus. So this theory explains endometriosis in this site. And according to direct implantation theory, The endometrial or decidual tissues start to grow in susceptible individual when implanted in new site. The iatrogenic dissemination during surgery explains the endometric implant and scar tissue. Such site, such site are in abdominal scar following hysterectomy, caesarean section, tubectomy, and myomectomy, and endometriosis at episiotomy, scar, vaginal or cervical site can also be explained by this theory. So, the direct implantation theory provides the explanation for the endometriosis in the scar tissue. Now, in the vascular, now another fifth one is vascular theory. In this theory, according to this theory, it explains the occurrence of endometriosis in lungs, arm, and thigh distant side. The blood carries the tissue and implant to this site. So again, there are various other theories like genetic and immunological factor explain the endometriosis. There is autoimmune basis of endometriosis. There is due to abnormality in cellular and humoral component. There are various there is various involvement of cytokines and growth factor in the pathogenesis, and also there is a genetic basis and familial predisposition to endometriosis. So these all explain the endometriosis, and also the environmental theory due to the mutation in the cell and due to the environmental factors. There is like pollutant, dioxin. There can be endometriosis, especially the deep infiltrative endometriosis can be explained by the environmental theory. So this was all about the environmental theory. About the different theories of endometriosis. There is no fixed theory; all have their significance. So that was about the pathogenesis of endometriosis. So now we will talk about how the pathology about endometriosis. So now there we have to consider some general point. The endometrium has potential to undergo changes under the action of ovarian hormone. Just like normal endometrium changes under the action of ovarian hormone, this endometrium also changes under action of ovarian hormone, and there is the proliferative changes are constantly evidenced, but very evident, but secretory changes are not so. They are absent. Secretory changes are absent, unlike normal endometrium. Also, there is cyclic growth and shedding of the endometriosis tissue, and these continue till menopause. The periodically shed blood may remain encysted, and else, and the cyst remain tense, and the cyst may rupture due to cyclic growth and bleeding. And the blood is very irritant, and it causes dense tissue reaction, the surrounding tissue that result in fibrosis of the surrounding tissue. And if it happens to occur in pelvic peritoneum, it produces adhesion and puckering of peritoneum. These are very important points. So conceptual and very important point that explains the endometriosis. And the deep lesion with penetration greater than 5 mm are called deep infiltrating endometriosis, DIE. Deep lesion with greater than 5 mm penetration. And also when encysted, the cyst enlarges with cyclic bleeding. The serum gets absorbed in between, whereas the remaining content inside becomes chocolate colored. Hence this cyst is also known as chocolate cyst, which is commonly located in ovary. The chocolate cyst may also be due to hemorrhage, follicular, and corpus luteum. So this was about chocolate cyst. It is also known as endometrial cyst or endometrioma. And this is another terminology we can use for chocolate cyst. So we have also talk about that, and in endometriosis, the fallopian tube is patent. And talking about the gross and microscopic appearance of endometriosis, in the naked eye appearance, so that the appearance of lesion depends on great extent on organ involved. It depends on extent of lesion, and it also depends on reaction of surrounding tissue. The early lesion may look like very papular or vesicular. In pelvic endometriosis, typically there are a small black dot. There are a small black dot. Is also known as powder bone. In pelvic endometriosis, there may be small black dot are found, and that is known as powder bone. It is called powder bone. It is seen on uterosacral ligament and pouch of Douglas. The fibrosis and scarring in peritoneum surrounding the implant also has a typical finding. Other subtle appearance are red flame-shaped areas, red polypoid areas, yellow-brown patches, white peritoneal areas, circular peritoneal defects, or sub-ovarian adhesions. These lesions are thought to be more active than powder bone. So there are various different lesions that are seen in naked eyes. So that was about the neck gross appearance. And talking about macroscopic appearance of endometriosis, there is presence of over endometrial tissue. There is presence of both gland and stroma, as we already discussed in our definition part. There is both gland and stroma. Due to pressure effect, the lining epithelium of cyst may be absent or flattened. So not so important point. So that was about this. One important point in my microscopic feature is that the phagocytic cell are laden with blood pigment. The phagocytic cell engulfs the blood component, and they are filled with the blood pigment that is hemocytated, and that cell is known as pseudoxanthoma cell. So that was about macroscopic feature. These all are the point that are mostly important for the second year student who are studying pathology, but might not be important for clinical student who are reading gynecology. So that was about pathology, and now we will talk about the one of the most important topic of this video, that is the clinical feature of pelvic endometriosis. The clinical feature of pelvic endometriosis. The patient is usually in the age of 30s to 45 years, and they are mostly nulliparous, or they may have 1 or 2 children long years prior to the appearance of symptoms. There is infertility, there is voluntary postponement of first conception until a late age. There is, and often higher social status is related to the endometriosis. There is family history of endometriosis, and in teenage there is outflow tract obstruction. So that was about patient profile. And talking about symptom, around 25% of the patient do not have any kind of symptom. They remain asymptomatic, whereas remaining 75% have some symptoms. And also we have already discussed that symptoms are not related with extent of lesion. Even if there is endometriosis is widely spread, there may not be any symptom. And even and also conversely, even with little or minimal endometriosis, there can be very intense severe symptom. So symptom is not correlated with extent of lesion. That is very important point. And also there is depth of penetration is more related to symptom than spread. Okay, depth is more important. More the penetrating lesion, there is more the pain, and more the dyspareunia or other symptom. And also non-pigmented endometric lesion are more symptomatic, more painful. Also the symptom are mostly related to the site of lesion. And that was all about endometriosis and general condition how the symptom present. So talking about symptom, the first and most common symptom of the endometriosis is dysmenorrhea. It is found in 70% of the women. It is found in 70% of the patient. It is the most common symptom. There is progressively increasing secondary dysmenorrhea. The pain starts a few days prior to menstruation, and they get worsened during menstruation, and takes time even after cessation of period to relief of the pain. So that was about dysmenorrhea. And how does pain occur? And this the main factor that is responsible for the pain is prostaglandin F2 alpha, thromboxane, and these two these two chemicals, these two prostaglandins from released from endometrial tissue causes the pain. Especially prostaglandin F2 alpha is important. And infertility is found in 40 to 60%, and it is second most common symptom. And multiple factor cause in infertility in endometriosis. That is another symptom. And thirdly, the another symptom, important symptom is dyspareunia. That is pain during sexual intercourse, and this is usually caused due to stretching of structure of the pouch of Douglas, or there can be direct contact tenderness. So that may cause dyspareunia. And abnormal uterine bleeding, it is featured in around 15 to 20%. The data is not important. We can just remember this: dysmenorrhea, infertility, dyspareunia. There is abnormal uterine bleeding in the form of menorrhagia. There is menorrhagia, or there can be polymenorrhea or epimenorrhea. So what are the meaning of this term? The menorrhagia means the menstruation is either in excessive in amount, greater than 80 ml. It is either menstruation is in excessive amount, or it is for more duration is greater than 7 days. It is for more duration. If it happens, then it is known as a menorrhagia. And the polymenorrhea means the cycle is, there is frequent cycle. The cycle is less than of 21 days cycle. So there is frequent menstruation, and that is called polymenorrhea. And epimenorrhea and menorrhagia, polymenorrhea are same thing. They are synonymous. So that was about menorrhagia, polymenorrhea, or epimenorrhea. So that was about the abnormal uterine bleeding. And the chronic pelvic pain, that is another symptom of endometriosis. The pain may vary from even the pelvic discomfort to the lower abdominal pain, backache, and the cause of pain is multifactorial. The pain may be either due to the various peritoneal inflammation, just I said, the prostaglandin F2 alpha, tissue necrosis, adhesion formation, nerve irritation, or there may be local inflammatory mediators, or the pain may be due to endometrioma formation. And the pain usually aggravates during period. And this point might be useful in while asking the history of the patient. During we just ask about the pain in the term of shock rates, and during shock rates in the A component we may find this. We may explain the history like it aggravates during the period, the chronic pelvic pain, and there can be abdominal pain. So these are about the symptoms of menorrhea, endometriosis. So some other symptoms that is related to organ involvement are urinary. If there is urinary endometriosis, then there can be urinary symptom like frequency, dysuria, hydronephrosis, back pain, or hematuria. If it occurs in sigmoid colon and rectum, there can be painful defecation, that is known as dyschezia, painful defecation, diarrhea, constipation, rectal bleeding, melena. And if it occurs in lungs, it may cause hemoptysis. It may cause catamenial chest pain if it occurs in pleura, and it may in the surgical scar site there may be cyclical pain and bleeding. So that was all about symptom of endometriosis. Now we will talk about how this endometriosis is diagnosed. So the one of the most important point for diagnosis is history. So based on all the given symptom, we have to rule out the endometriosis, and next thing is examination. In the speculum examination, we may find a bluish powder bone lesion on the vagina and cervix. And in the speculum examination, in the bimanual examination, we may find nodularity in pouch of Douglas. We may get some nodular field on the uterosacral ligament, and we can find the fixed retroverted uterus. Due to adhesion, the uterus turns like this. Normally the uterus and vagina make angle of, what is the angle? Just okay, I will say, just you write in the comment section what is the angle of antiflexion. Write in the comment section what is the angle of antiflexion, the angle between normal cervix and vagina. In retroversion, There is the uterus turn or uterus gets displaced, and it causes fixed retroverted uterus. So there is unilateral or bilateral adrenal mass, adnexal mass. So that was about, and that is chocolate cyst in the ovary, and that was about the examination. We may find this thing in examination that may help in the diagnosis. Now after the history and examination, we will send the investigation. The serum markers for endometriosis is cancer antigens CA125, and the value greater than 35 international unit is diagnostic, and there is elevation of monocyte chemotactic protein MCP1 in the peritoneal fluid. The MCP may be increased in the peritoneal fluid of the patient. Peritoneal fluid, and this is in serum. So not to be confused, we have to find this in serum, and this is in peritoneal fluid, CA125. This one is more, and the value greater than 35 international unit is not diagnostic, but it may point out to the endometriosis. And also CA125 is raised in some other lesion. What is that lesion? Please write in the comment section. Okay, I will say it with myself. In the epithelial ovarian carcinoma, the CA125 is raised. So this is not the specific test for the endometriosis. And next we have to do the imaging modality. We have to do ultrasonography. The transvaginal scan can detect ovarian endometriomas. The transvaginal scan and endorectal ultrasound, ERUS, endorectal ultrasound, they are found to be better for the rectosigmoid endometriosis, and also these two are helpful in especially in the diagnosis of deep infiltrating endometriosis. And next modality we can adopt is MRI. MRI is one of the best diagnostic tool for the diagnosis of endometriosis. There is characteristic hyperdensity on T1 weighted image, and it is one of the best diagnostic tool. The fourth one is CT scan, and next one is laparoscopy. It is one of the gold standard for endometriosis, and it is investigation of choice for diagnosing endometriosis. It is very gold. It is gold standard, and confirmation of endometriosis is done by the double puncture laparoscopic or by laparotomy. And we have okay, talking about more detail about laparoscopy. There are various other benefit of laparoscopic as well, like the laparoscopy can determine access the lesion according to their size and lesion site and extent. Biopsy can be taken during the laparoscopy. At the same time, staging can be done, and the extent of adhesion can be recorded during laparoscopy, and we can get the opportunity to do laparoscopic surgery if that is needed. So we will see some classic lesion like we have already discussed. We can see the powder bone or matchstick spot on peritoneum, and so that was about laparoscopy. This is the gold standard for diagnosis of endometriosis. Next is intravenous urography, and it is useful in the case of DIE, deep infiltrating endometriosis. And finally we have biopsy confirmation of the excised lesion, that excised from the laparoscopy, and biopsy confirmation of the endometriosis. So that was all about diagnosis of investigation of endometriosis. So what are the differential diagnosis of endometriosis? So if there is a ovarian endometrioma, so the possible other diagnosis can be benign ovarian tumor if the lesion is asymptomatic, and malignant ovarian tumor. These two are differential diagnosis for ovarian endometrioma. And if there is rupture of chocolate cyst, sometimes the chocolate cyst can be ruptured during the operation, and that may cause acute abdomen, and that should be differentiated with other causes of acute abdomen like torsion or rupture of ovarian tumor, disturbed ectopic pregnancy, appendicitis, diverticulitis. These may also cause acute period abdomen. So this differential diagnosis should be kept in mind. And another differential diagnosis we have to rule out is chronic pelvic infection. And so this is confused with symptomatic endometriosis. So that was all about differential diagnosis, and now we will see about complication of endometriosis. So what are the complications of endometriosis? One is endocrinopathy, and this endocrinopathy may be responsible for infertility. There will be rupture of a chocolate cyst. There can be infection of chocolate cyst. There will be obstructive feature like intestinal obstruction, urethral obstruction. There can be urethral obstruction that will lead to hydroureter, hydronephrosis, and finally that may cause acute pyelonephritis. So, and also the ovarian cancer risk is increased 4 times in endometriosis. So that was about endometriosis, complication of endometriosis. Now we will finally move on to the treatment of endometriosis. Okay, the video has become too long, so we will talk about in treatment of endometriosis in next part, in the part 2 of this video. So stay tuned, and so thank you, and let's see in the next video.